Hi everyone. It's amazing to see MLHC come together during the pandemic. It's virtual, but we're making things work, and that's fantastic. So thank you for being here. Our first Q&A this morning is with Robert Califf. He's the head of clinical policy and strategy for Verily and Google Health, formerly FDA commissioner, distinguished professor of cardiology and doing clinical research at Duke. So has seen things across industry, academia, and government. It's a real pleasure to have you here.
Thanks. It's great to be here with you.
And so let's get started. So I was listening to your talk, and one of the things that really struck me when I was listening to your talk is just this emphasis on how we really need to think about healthcare in the public health, in the health at home, rather than just health in the clinic. Do you want to speak a little bit about that?
Sure. I think it's just a well-known fact going back over 100 years that if we look at health as opposed to health care, the largest determinants of health are not what happens in a medical clinic or what doctors do. The largest determinants of health are the social determinants, that is, everyday behaviors, social interactions, economic status, education. And at least the way I think about it, if we go back historically, there was a big division that occurred between medicine and public health that really was driven by the Flexner report over a century ago that basically told medical schools to focus on biology, that was the basis of health. And then schools of public health arose, which were focused on more social issues and population health. And in fact, if you go to Johns Hopkins, it's really fascinating. You can actually walk around the campus and see that old division still playing out with one of the dominant schools of public health in the country and also a great medical school. But one of the fundamental problems that we had in bringing these two worlds together is that there was no way to compute. Doctors and hospitals and clinics are focused on the medical record, one patient at a time. Schools of public health were focused on populations, sampling, because you couldn't measure the whole population at the same time. Now suddenly we don't have these limitations anymore. We can compute the whole thing. And this is where I think the meeting that you're holding is really important. We can actually bring these worlds together at the level of the individual or at the level of the sum of individuals into a population. And we're not limited to the medical record. There's a lot of critical social information in the data fabric that exists.
Yeah, we can definitely see how data produced by people interacting with various devices and the health system eventually come together to produce even more higher quality data, more complete data, holistic data about what people are up to. What do you think about what are the key action areas? Like I think of myself, doing machine learning in healthcare, and the sort of action spaces sometimes we're considering are quite, they seem quite trivial, like vasopressor versus fluid or something like this. And here we're talking about helping people through, as you mentioned, the complexities of their social, economic fabric of their lives in order to improve their health. Like, where do you think are the key leverage points in helping really make changes to improve healthcare or health?
Well, I mean, first of all, I'd like to note that I made my living as a critical care doctor for most of my career, so I do not want to downplay that at all. When someone does get sick, taking good care of them, using the best knowledge possible is really highly valued by our society. It should be. So I don't want to downplay that, but we need to really consider the other part. And I think the greatest area of leverage is that most health outcomes are determined by a fairly small set of repetitive behaviors. And when I say small, that's not it's complicated, but essentially 80% of death and disability really in the world today, because it used to be, I used to say in high income countries, but even middle income countries now are seeing the same thing. 80% of death and disability is caused by a relatively limited number of common chronic diseases:
Mhm.
diabetes, cardiovascular disease, kidney disease, cancer, um, uh, and so on. It's actually not that large a list when you look at it. And at the core of all of those problems are a set of behaviors. What do you eat? Do you exercise? Is your basic mental health in good shape? That is, this is largely driven by depression and anxiety, which are highly prevalent in our society. And then there's, are you getting the right medicines? And do you actually take the medicines if you are prescribed the right medicine, so-called medication optimization and adherence? So, um, if you look at any of the common chronic diseases, these basic elements are in play. Um, and so I think that's a great area of leverage. The other
Mhm.
one that I point to, which is a huge issue in the pandemic that we're currently experiencing, is summing the input of many individuals into a geospatial fabric based on normal social units like neighborhoods,
Mhm.
counties, zip codes, um, so that local policies can be made in a public health sense in a way that optimizes for the population as well as the individuals in that population. This is a huge area where a lot of good work is already being done, but making that better is a really important part of what we need to do.
Absolutely. And in your talk, you also mentioned just getting people the right information to encourage them to make appropriate decisions. And I was wondering if you could speak a little more to that as well. Like, do we need to work on, we're so good at manipulating people in terms of targeted advertising and things like this. Where do you see us, or how do you see us using all of these things that produce, maybe undesirable behavior change, keep us sitting at games and things all day long, to actually provide us the right information at the right time and actually change our habits to be healthier?
Well, I think there are a couple of key points, at least the way I think about it. And I learned a lot about this at the FDA. And maybe the best example to use from the FDA was the food label, where, I had a lot of fun because I got to work with Michelle Obama, and she is pretty fantastic to work with and extremely energetic. But the fundamental problem that we had at the FDA is that you have, as we were updating the food label, is that you have a very limited little box that's limited by law to a certain size that has to be put on each item of packaged food. And you have to get the message across within that little box to 320 million people who have all different levels of education and all of whom do not speak English, et cetera. This is really, really hard to do. And you can't get it perfectly right. So having said that, I think the areas that really deserve a lot of focus right now is first understanding that health information is different. There's an art and science to advertising, and I also got to see that really closely when we were doing the anti-tobacco advertising from the FDA, where we had a big budget and ability to use the experts. And I'm certainly seeing it when I work on the Google side of my job. But what's different is that most advertising is built around the connection of the human brain with gratification.
Mhm.
And, I would argue that's a relatively easy connection to trigger compared to what we need for health, which for the most part is triggering the executive function. That is the ability to defer gratification by doing something that might not feel so good right now, like spending money on medications or not stopping at McDonald's or not smoking that next cigarette. Um, a lot of what you need to do for health requires the ability to defer what you would do if your goal was to immediately have gratification. And that's an area that a lot of basic research needs to be um, done in. And, I think it explains why, at least part of the reason why we see such difference in health outcomes according to education and income, because people who are more highly educated and sort of persevere through that system tend to have well-developed executive function. They study for exams and all that sort of thing. But how to reach the whole population and improve these health habits is really critical. Getting back to what you said at first, there's only so much we can do if you come to the hospital sick. And while I think that's really important, the more important thing to do would be to help you live a better life so you don't need to go to the hospital.
For sure. So we've got one question coming in from the audience that mentions that in your talk, you talk about how technology and machine learning can help alleviate health disparities or exacerbate them. And a lot of technologies that are out there meant to be gathering data in the wild are centered around wearables, which are currently quite expensive. So do you think that, focusing on, we started out this Q&A with, there's these amazing data streams that are now available, but are you concerned that those data streams are only available for certain subsets of the population and we may end up actually exacerbating disparities?
I think there's a lot of reason to be concerned about it, and I know that there are talks at this meeting about that topic, particularly although my colleague from Berkeley has, I think, a really good talk about specific examples where algorithms actually reinforce disparities. And this is this, again, this is just my opinion, but this is an enormous issue in the United States, particularly because the payment structure of a healthcare system basically increases disparities because the margins that are made on high-end procedures, high-tech things accrue to people who are well insured to begin with. Whereas in societies where healthcare is a right, it's a very different dynamic in terms of what a healthcare system would do.
We were right, and we were talking about this a little bit right before, where if you have a value-based system, then perhaps that would encourage more. I'm extrapolating here, more equitable data collection. That if we're doing a great job with certain populations because they buy Fitbits and they upload their Fitbit data to be shared with their health system data, and therefore we just know how to treat them because we have data. Then if we are focused on providing value to everyone, then maybe we find ways to close that data gap, which then ends up producing disparities in care.
Completely agree. And one thing I have no lack of confidence in is the ingenuity of our culture in solving problems. Once a problem is identified and solving it is rewarded. So I just see this over and over here in Silicon Valley that what looks attractive to a software engineer, for example, might be something that would be used by very few people who are from a different background. So what you see is an app or a technology is put out there, and the people who need it the least tend to use it. The people who are already activated, already in good health, and the people who really would benefit from it often don't use it. Now, I do need to point out that the cost of sensors and the ability to Bluetooth globally is just moving very fast. So I don't think the fundamental cost of goods is going to be the limiting factor in the future. In fact, I would expect that health systems will be giving away, whichever device they're using, Alexa or a Google device or some or another. And I think wearables are just going to be built into things that we have every day. And, one way to get through this technology disparity issue is to go to more things that are passive sensors so that the person doesn't have to do something active to make it work. But then that gets into another area where I think there needs to be an enormous amount of work, and that's on the ethics and privacy issues related to this technology. It's like a nuclear weapon.
Yes.
If used appropriately, it can be tremendously helpful. Maybe nuclear weapons not the best analogy.
Nuclear energy, nuclear power.
Yeah,
Right.
nuclear energy, that's good. Nuclear power. If used
Right.
appropriately, it can be tremendous good, but if used inappropriately, it can magnify the harm.
Yeah. So there's one more question that came in also on this related note about, like, what do you think is the interplay in the discussion about the need for societal equity overall and individual health behaviors?
Well, I think like a lot of complicated human issues, there's not a single optimal solution. And I also think that we often use the term equity and assume that that is the goal for everyone who's making policy. And I would just put forward the idea that that may not be the goal of everyone who's making policy. And particularly in countries like the United States, there's a history of the individual taking priority over society. And I think my views on this are well known. That I think we need to give more credence to the values of equity and good for all. But just assuming that that's everyone's goal, I think, is a mistake. And so, if we believe that's a goal, we have to articulate it and then articulate the pathway to get there. And one thing I often think about in this regard is that in many of our competing or collaborative societies, whichever way you look at it, being poor doesn't necessarily mean that you have bad health. That's also true in the U.S. It's just that the correlation in the U.S. is greater than in almost any other country right now, at least among high-income countries. And the result of that is that we're in last place in terms of longevity of all the high-income countries, and we're losing ground. We're the only country with an almost continuous decline in life expectancy for the last 5 years. And so until we articulate it as a goal and then map out the pathways to change it, our course is defined right now.
Sure. So I'm going to ask 3 relatively quick questions since we're getting close on time, but they're all good ones. So the first one is, given your background at the FDA, I'm going to paraphrase this question a little bit to make it a little broader. What do you think is the role of RCTs, or let's just say regulation more generally, in terms of promoting innovation while also getting appropriate levels of safety? Right now, there's also a gray area between QI and research with different implications. What do you think that system should look like, especially in the context of machine learning and AI in the health area?
Wow, we could spend the next.
We could spend forever. So try to give a 30-second, 1-minute answer.
Yeah, let me just note that when President Obama offered me the job as FDA commissioner, that was the topic that we talked about. I know this meeting is centered at Duke, and we did spend 10 minutes on basketball because he's a big UNC fan, and I have the heritage of Duke basketball. But I don't think we actually know how to regulate the digital component yet, but we did put policies in place which have been continuous through the current administration. What we need is something where iteration below a certain threshold is encouraged, but where when it's a big change that's occurring or something that's going to be deployed broadly, more traditional evidence generation is done, including randomized trials. I think one of the great things about the computational environment now is we can do randomized trials very quickly. And we can use things like cluster randomization within health systems to get answers at the unit level in ways that are much more efficient than individual randomization. So I'm optimistic that we'll get there, but just allowing willy-nilly innovation in healthcare would be a big mistake.
Cool. So the second question is something that we touched on before the session started and relates to a question that was asked is, we talked a little bit, you mentioned that, value-based care is a good thing. It produces the right incentives for systems to provide care for everyone. There's this question of how do you measure value? When people have multiple goals, multiple morbidities, what's the role of machine learning in this space?
Well, I think when I look at the world of machine learning that I'm exposed to in the alphabet universe, I mean, a lot of it is very well applied to optimizing logistics and efficiency of systems. But of course, when you do that, you're optimizing to an outcome that you can identify. And I worry a lot that what's happened with our health systems, particularly in the US, is that we're optimizing to the financial outcome. And because measuring clinical outcomes is much more difficult, particularly measuring them over time, that we tend not to focus on the clinical outcomes. And of course, if we optimize on finances, we get what we have, which is profitable health systems, but poor health outcomes. As I say, the worst of all high-income countries. So I'd really love it if machine learners got very focused on measuring clinical outcomes, and not just in the hospital, but clinical outcomes where it matters. How long do people live? What is their quality of life? How functional are they when they're going about everyday life? And I think we're in an era where this can be done, thanks to what you said before about low-cost wearables and other methods of people contributing their information without having to take time out and go to a clinic and sit in a waiting room.
For sure. So last thing, much of this has been focused on, what can people in this community do in their professional lives to, support this vision that you had, which is fantastic. How do we actually get this change though? Because we need some incentive structures to actually change for this vision to come through. Like, what else do we need to be doing besides doing our math and treating our patients?
Well, I'm going to skate the tightrope as closely as I can here. I was a presidential appointee, so my politics are known. But, the things that I think are really important to do are, number one, vote. And, you can probably guess how I think you should vote, but look carefully at that, both at the local and the national level. Number two, do not underestimate the value of getting to know your elected representatives personally. I sort of knew this, but it was really amazing to me to see how often a personal relationship with a politician changed that politician's view. And I don't mean that in the sometimes you think of, well, lobbying and all that. That is a big deal in the US, but I'm really talking about passionate people about a subject. Going to visit politicians in their offices and making sure they develop a relationship and talk, you can have an impact there. And then the third thing, especially now in the pandemic, I'd say set an example in your own life. If you believe in equity and that analyses can lead to more equity, then spend time volunteering and involving your family in volunteering. So I think just like anyone else with a high professional standing, anyone who can do what you all do for a living is in a very privileged part of society. And I just say be aware of that and make good use of the privilege for the benefit of others.
So we're basically at time. Thank you, Dr. Califf, for joining us. If you want to see more, hear more, please check out the talk. It's on our YouTube channel. And then we're going to just take a 2-minute break before we start with our next speaker.
Okay, thanks a lot.